Yeah, the work we are doing is trying to characterize the lipid mediators derived from polyunsaturated fatty acids. And these are related to the SPMs because the SPMs are generated from the omega-3 fatty acid metabolism. So all the omega-3 polyunsaturated fatty acids are metabolized further into highly physiologically active compounds. And we do analyze all sorts of samples and to identify and quantify the levels of these SPMs in those samples. And this is the way to gauge their physiological relevance and how they participate in inflammation as well as resolution. Yeah, one of the most recent work that we have done is the analysis of human amniotic fluid of obviously pregnant women. That study revealed a complete lipidome profile of the human amniotic fluid. For almost 85 years, we all know that prostaglandins are highly elevated in the amniotic fluid at term before the onset of labor. And because of that, they have been assumed that the pregnancy is a model of inflammation. But when you look at it, there is no inflammation in pregnancy because the baby bathes in the amniotic fluid for almost 12 to 24 hours before it is expelled. And at that high concentration of prostaglandins, if they are inflammatory, the baby would not survive. So how is it that the baby is surviving even in those conditions? Our significant finding is that we found a whole host of other lipid mediators derived from polyunsaturated fatty acids, especially the anti-inflammatory lipids called epoxy fatty acids. And it looks like they are the ones that are balancing the inflammatory propensity of the prostaglandins inside the amniotic cavity. And that's actually what led me to, of course, there's a whole host of other samples and whatnot that led me to propose the new paradigm called unalamation, actually. So that was the most significant finding, actually, that we did. The concept of unalamation, in fact, it took me almost 4 years to come up with that name. The unalamation, the name originates from the word Sanskrit analam, which is supposedly a mythical fire in your stomach that burns the food and sustains life. And in this case, all these so-called inflammatory mediators, prostaglandin E2, they are not really doing any inflammation. They are sustaining life. That's what this whole concept is. So the prostaglandins got this bad rap that they are inflammatory. No, they are not inflammatory. They're just simply mediators. Depending on the context, they can be inflammatory if they are produced under injurious conditions. But if it is under normal homeostatic physiology, like for example, your brain makes a lot of PGE2, your kidneys make a lot of PGE2, your intestinal epithelium produces millimolar quantities of PGE2. These are all serving a normal homeostatic purpose, not an inflammatory purpose. Inflammation, by definition, is a defensive mechanism. So the prostaglandins that are produced when there is injury to the body, there it is, yes, they do induce inflammation, they induce immune response, and they protect the body. When the prostaglandins are not involved in inflammation, in a normal homeostatic, everyday happy-go-lucky life, they are participating in normal developmental physiology. And to make a distinction, because you have to identify that, you cannot say, oh, this is another facet of inflammation. Because if you think it is inflammation, then non-steroidal anti-inflammatory drugs will stop that one. That means you are stopping homeostasis. So to identify this separate from inflammation, I had to come up with this name. And I waited because until I have the correct name, I don't want to publish this concept. So that's when I came up with the name of unalamation. Now, what happens is, if, for example, if there is some disruption in the unalamation process, that means the role of these quote-unquote inflammatory lipid mediators, if for some reason they start creating inflammation, then the anti-inflammatory mediators are not doing their job in controlling them. That's when the SPMs come into role and say, correct this situation. Okay, now this is not an inflammatory situation, so the SPMs could potentially help bring this system back to homeostasis, even in those conditions. Obviously, SPMs play a major role in reducing or mitigating the effects of acute injury, acute inflammation. But in this case, it is probably to some extent in the unalamation, which is if the disruption of an unalamation could cause chronic inflammation. And that's where the SPMs could play a role in reducing. Yeah, actually, the major human amniotic fluid study we did, there was something very interesting that came about. There is a condition, a term, it is an inflammatory condition, a term called clinical chorioamnionitis. This is an inflammatory condition where both the mother and baby have fever and tachycardia and foul-smelling vaginal discharge and neutrophil infiltration and a whole host of things. It is a typical inflammatory condition. So what the general assumption has been that there is intra-amniotic infection that caused this inflammation. And physicians don't have that much time to wait for the culture results of the amniotic fluid to see what are the microbes. So they started prophylactically treating them with antibiotics. In the retrospective study that they did, the PRB did back in I think it's about 10 years ago, they found that only 56% of all the chorioamnionitis cases have intraamniotic infection. That means 46% of the patients are receiving antibiotics. The babies are being exposed to antibiotics for no good reason. So how are they going to prevent that from happening? So if you were to take the transabdominal amniocentesis, amniotic fluid from transabdominal amniocentesis, and you culture them, it takes 3 days for you to identify what the microbe is and then to treat with proper antibiotics or whatnot. You can't have the mother and baby with fever for 3 days without any treatment. So that was their dilemma. So they're erring on the side of using more antibiotics. So what we found was that it was actually a very interesting story when they told me these are the 35 cases of the 180 that have clinical chorioamnionitis. And then I looked at the data of all those 35 cases. I said to myself, there is no way that could be one homogeneous group of patients. There are at least 2, if not 3 different groups. And then I asked the physician who gave me those samples, can you tell me if there is any heterogeneity in this group? Then he looked at his database and said, there are some of the patients have infection, some don't. I said, stop right there, because I want to tell you which ones are infected, which ones are not infected. So I looked at it, and leukotriene B4 is present only in one set of patients. It is completely absent in the other set of patients. Then I segregated those 2 groups and said, these are the people who got intraamniotic infection, the one that contained leukotriene B4. These are the ones that do not have infection. Spot on, 100%. So what does that tell you is that if you do transabdominal amniocentesis of a patient that has clinical chorioamnionitis and you measure the levels of leukotriene B4, in fact, even just the presence or absence of leukotriene B4 itself is good enough. And if there is no leukotriene B4, then there is no infection. You don't need to treat those patients with antibiotics. If there is leukotriene B4, yes, you can go ahead and do it. See, the advantage of it is that leukotriene B4 can be measured within 30 minutes, right bedside to the patient. So you don't have to wait for 3 days, or you don't have to wait for prophylactic, you don't have to treat the patients prophylactically with antibiotics. This is a major development in there. I hope PRB is going to follow up on that study and do more extensive validation to give clinical guidelines. So this is one thing I would say is probably a major impact on that one. Omega-3 fatty acid intake, everybody for how many decades knew that it helps. But in almost every clinical study or controlled experimental study, the results are always mixed. Some say, yeah, they helped, some say they didn't help. The reason is they were looking at only the primary polyunsaturated fatty acids, omega-3 fatty acids, whether it's EPA or DHA, but not looking at further downstream metabolites. Those are the ones that really make the difference. So in my opinion, based on my experience especially with the SPM active, it's just my conjecture at this point, is that some people are missing the metabolism, the first step of the metabolism of these polyunsaturated fatty acids. And if those people who are missing that one, they will be benefited from the SPM active, like fish oils. The reason is, if you look at it, SPM active has a very high concentration of hydroxy fatty acids, especially they're quantified by 3 different ones, 18-HEP and 14-HDHA and 7-HDHA. And these fatty acids, we have been recommending people, I know for example, I know at least 30 people I know whom I recommended it. They have been taking gram quantities of regular clean fish oil for almost 15, 20 years. But they still have, one person has a chronic wound, another person has psoriasis and psoriatic related arthritis, and another person has lupus. So we have a whole host of, some people have fibromyalgia. So a whole host of things. And they have been taking fish oil, and they say, I'm taking fish oil, they're not helping up. Okay, I said, okay, why don't you try this special fish oil? I didn't tell them what that contains. I got some samples and then I gave it to them. And first they thought, maybe this is a placebo effect because you gave me, I think, that helped me. And then, okay, fine. They stopped after the sample I gave them, they exhausted, they stopped. Then they realized, oh, you know what? The last month I was using this fish oil, I felt much better. So then they started resuming it. All those, in fact, one of my friends, very close friends, he had been suffering with psoriatic arthritis for the last almost 20 years. After 2 weeks of continuous use of the SPM active, and he said, usually it takes me 30 minutes to get out of the bed and walk out. But these days, I just jump right out of the bed. And in fact, he told me about a year after he started using, he's a biochemist, he's a lipid biochemist, so he knows what he's talking about. He said his psoriasis is gone 95%, and he has no arthritis anymore. It's amazing difference. And I have other friends who have chronic wounds, gone. people, in fact, I'm collaborating with one of the surgeons, the wound surgeon. He looked at his patient and said, I've been, attending this patient for the last 10 years, and it looks like you are taking my job away because, this one cured it. And now he wants to see, he gives me the samples to analyze, okay, what are the difference between, treated versus non-treated, and what is it that is causing the chronic wound and all those things. Of course, those are still preliminary stages of the study. But that is, so what we are talking, in coming back to your question, if you take regular fish oil, if your body has all the biochemical machinery to metabolize those fish oils, yes, they will help you. But what if you don't have that first step enzyme, if you are missing or something happened and you are not being helped, then you are bypassing that first step by taking something like SPM active. And then you move on. So this is even though it is a conjecture, this is based on my observation that people who have been taking fish oil were still not benefited. But once they started using SPM active, then it completely changed their life. So that tells you, even if you cannot measure the SPMs in the peripheral circulation, I'll come back to that in a second, it is still being helped. So the proof is in the pudding. If I take this pill, I don't know what is in there, but if it helped me, obviously there is something in there that is helping me. For all we know, the difference between a regular fish oil capsule and an SPM active fish oil capsule is this characterization of these 3 different hydroxy fatty acids that made the whole difference. Now, when you take fish oil, do you produce SPMs? Now, this is I think I mentioned this before, this is $1 million question. The reason is this: if you have inflammation at a certain point, at a certain place in your body. It could be your brain, it could be your liver, kidney, vasculature, wherever it is. That is the local inflammation. And that's where the inflammation goes up and the omega-3 fatty acids start getting metabolized and they start actively resolving the inflammation. The local concentration of these SPM compounds could be very, very high. But what happens? Those organs are constantly being irrigated by the circulation. So your blood carries away those metabolites or those compounds. Now, when you are taking blood from the peripheral circulation and trying to measure whatever is the local concentration, and especially these compounds are so highly potent, effective down in the low nanomolar or even in the picomolar concentration, and you are diluting them in 7 liters of blood that in your body, then all significance is gone by the time you take the sample and measure. So what is the solution? Obviously, you can't poke a human being at their heart or at their brain to identify these compounds. So you have to really go with what you can do. In that aspect, we were really lucky to be able to analyze the amniotic fluid, because if you are doing transabdominal amniocentesis, amniotic cavity is a very privileged space. There is not much exchange going on between the rest of the body and the amniotic cavity. It means you are going to the source of the generation of these compounds and you are measuring. Of course, in that case, we didn't measure any SPMs. We didn't detect any SPMs, but that's besides the story. So there is again, like I said, there is no acute inflammation there. Only when there is acute inflammation, then there is a role for SPMs, because the macrophages start producing SPMs. So do the fish oil, metabolism produces SPMs? I think I'm almost certain they do. Otherwise, you won't see the effect of SPM active like supplements. Can everybody measure them? Sometimes if you catch the sample at the right time, at the right place, yes, you can. But it's not that trivial. So, especially in clinical studies, you cannot really time them exactly. If you look at the curves that Charlie published, you see there is a peak of inflammation. And as the peak of inflammation is reached, then you start producing SPMs to resolve that inflammation. That means you have a very narrow window to catch the presence of these SPMs. And because of that, it's not that easy to measure, but even though they are anecdotal evidence, all anecdotal evidence suggests that the SPMs are indeed being produced to help resolve that inflammation. So this is where, unfortunately, because this is only a nutraceutical, there is not much interest in the pharmaceutical companies to do any clinical studies. But I hope some companies try to do some clinical studies to make this point clear. Because I personally has suggested to at least 100 people that people whom I recognize them as having chronic inflammatory condition, I suggested them to use SPM active. And not a single person came back to me and said, no, this didn't work for me. This is, 100, this is, of course, I'm not a clinician, so this is not a clinical study, it is still anecdotal, but that's where I think the field has to move on, that there has to be some clinical study. This is for the benefit of mankind that has to be done. Actually, I'll give you another very interesting case. This is a close friend of mine. I don't want to reveal the name of the person. Unfortunately, he did pass away last year. He was diagnosed with prostate cancer. It was still localized. There was no metastasis. There was a biopsy done by another friend who was a urologist. And they said, okay, waitful watch. We don't want to do anything. So he and I were talking, and he has been an avid consumer of fish oil for as long as I know him. So then he started taking some low-dose SPM active. And we talked about it and said, why don't you go ahead and increase the dose? So he started taking 2 capsules per day. And then we said, maybe you should take more. Then he started taking 3, 1 in the morning, 1 in the afternoon, 1 at night. And in about 6 months, the reason why, in fact, they even did they detect prostate cancer and did the biopsy is that his PSA level was 12, so way above normal. So in about 6 months, he went for another PSA test. His PSA level was about 7. And the urologist thought, there is always some variation. We see this in different patients, so there's nothing to write home about, because the urologist didn't know what he was taking, because they're just a waitful watch, so there is no medication or anything like that. Then he came back and he told me that his PSA level was 7. And so they did another biopsy and said, okay, yeah, there is definitely a reduction in the number of detection, the cancer cells. But again, it is still there. So what we discussed, and then he said, okay, let's increase the dose. So we started taking 2 in the morning and 2 in the evening of SPM active. And 1 year later, he went to, again, for PSA test. And his PSA level came down to around 4. Then he asked this friend of ours, urologist, can you do a biopsy? He said, no, I can't ethically do it because you are not a candidate for biopsy at that level of PSA. Then he continued. In 1.5 years' time, his PSA level came below normal. And that was it. Unfortunately, what happened was there was another cancer condition, pancreatic cancer condition, that was detected in him. Unfortunately, one of the physicians, they missed and they didn't inform him that he has pancreatic cancer. Finally, that came out, and he continued to use these SPM actives. And because they detected pancreatic cancer, pancreatic cancer obviously is a very deadly disease, and they started doing chemo. Okay. What happens when you have when you give chemo to a patient? They lose all their hair, they become weak, and all sorts of problems, side effects. Can you believe that he did not lose even a single strand of hair after 3 rounds of chemo? Not even a single strand of hair. And I was telling all my oncology friends, my wife is a physician, so all her classmates, there are at least a half a dozen of them are oncologists. And when we had a get together, I was telling them, hey guys, do you want to use this for your patients? And they never lost a single strand of hair. They said, no way. I said, you want me to show you a picture of the person? And he lived with that pancreatic cancer for 2.5 years. Okay. In the end, because after the chemo, they still has this, pancreatic cancer specific antigen that they're measuring. I think it's called CA19, I think. They still are measuring that. So because of that, they kept on giving more and more to radiation treatment, some other treatment and all those things. Only when they switched from normal chemo to some other medication, that's when he lost his hair. But until then, no problem. And in the end, he died of side effects of the treatment, not because of cancer. So this is an N of 1. And I personally measured, he used to, whenever he goes to the clinic to give blood for other tests and whatnot, he always used to ask them to give me another tube of blood, I want to take it home. So he used to bring it to me to the lab. We measured, we detected SPMs in his blood. Yeah, so do they help? Yes, absolutely. Do we have large enough cohort to make a definitive statement? Not yet. So that's where I really urge these companies, including Metagenics or anybody else who's providing these compounds, should do some really good clinical studies to make their point. There are only few analytical labs that can reliably measure these SPMs. Yes, there's your regular LCMS analyses and whatnot, and then anybody has a pocket full of change can buy a mass spec and then start doing that. But the metabolomic analysis, you need to have a lot of knowledge of chemistry. I think that's where it is. Not everybody can do it. So we need to spread that part of knowledge to a broader group of analysts. The other thing is this is actually a bigger challenge for clinicians rather than anybody else, is that how we can get to the source of inflammation to collect sample so that we can make a definitive case of, yes, there is inflammatory mediator. Yes, there is, SPMs that are produced during the resolution phase. Yes, by giving more fish oil, then you are generating SPMs. And so this is our biggest challenge. By no means it is an easy problem to solve because human clinical studies are not that easy to solve that way. Animal model studies, I'm sure we can do a lot of them, but still, we are not trying to treat the chronic inflammation of a mouse. We are trying to treat the chronic inflammation of a human being. Until you show that, yes, this is what is happening biochemically, people may or may not be convinced that so this is the big challenge. But I think short of that is we continue to measure whatever sample we can get. And the other thing that can help the field move forward a lot is SPMs, even though they were discovered more than 10 years ago, the field is still young. We don't know much about the metabolism of these compounds. For example, prostaglandins. We know exactly if PGE2 is produced in the body, elevated, we won't detect PGE2 in blood because it is so unstable. It gets metabolized. but we know all the downstream metabolites. So if we measure the metabolites, we know there is PGE to produce. Something similar to that has to happen in the case of SPMs. What are all the different metabolic pathways of the SPMs? Can we detect those specific metabolites in, say, for example, in urine or even in peripheral blood? Because that you have a much better chance of measuring those, because once the SPM is produced, it does its job. Obviously, it gets metabolized. Once it's metabolized, it has to be excreted. That means it is going to appear in urine or feces or sweat or something, which means it's also there in the peripheral blood. So if we characterize the downstream metabolism of these SPMs, then we can do a lot more clinical studies. So this is again another big challenge, because we need to take these compounds and give it to the elucidate all the pathways of their metabolism. So that is a big challenge. That is actually I see the field need to move on to firm up the position of the role of SPMs in this health.